Kindly be seated. I want to welcome everyone here to the 389th inaugural lecture series of Obafemi Awolowo University, Ile-Ife, titled The Visible Pathologist, a paradigm shift in the practice of education from the Sub-Saharan Africa Foundation for Advancement in Medical Education and Research, Cape Town, that was South Africa, from 2015 to 2016. She also obtained a Master of Philosophy in Health Professions Education in 2018 from the prestigious Center of Basic Medical Sciences. Outside the university, she has served as honorary consultant, OAU-THC 2001 to date, head of Department of Morbid, Anatomy and Forensic Medicine, OAU-THC 2010 to 2012, and from 2015 to 2016. Visiting clinical fellow, Department of Histopathology, Nottingham University Hospital, Nottingham, UK, 2014. Visiting professor, Department of Anatomical Pathology and Forensic Medicine, College of Health Sciences, Osun State University, Osogbo, Osun State. Professor OMONIYI-ESAN is an external examiner to many medical schools in Nigeria. Iwo, University of Lagos, University of Ibadan, Olabisi Onabanjo University, and then the University of Ilorin. She is also an examiner to National Postgraduate Medical College, Faculty of Pathology. She has delivered public lectures at various times on breast and cervical early detection and management to different women groups. Professor OMONIYI-ESAN is well published, both locally and internationally, and has to her credit over 65 academic publications and contributions to books and articles in reputable scientific journals. She has supervised several Part 2 fellowship dissertations of the National Postgraduate College of Nigeria and West Africa College of Surgeons. She has also supervised and examined many MSc and PhD theses. She's a member of several professional bodies, notably Nigerian Medical Association, the College of Nigerian Pathologists, Medical and Dental Consultants of Nigeria, Medical Women Association of Nigeria, British Division of International Academy of Pathology, West African Division of International Academy of Pathology, and the Postgraduate Medical College Fellows Association. She has attended and presented research papers in several local and international conferences. She's a reviewer for many local and international journals as well. She's blessed with children. I hereby call on Professor Ganiat.
This 389th inaugural lecture of Obafemi Awolowo University, titled The Visible Pathologist, a paradigm shift in the pathologist, a paradigm shift in the practice of an anatomic pathologist. On this special day, for he works all things after the counsel of his own will. As the preacher said in the book of Ecclesiastes 9:11, I returned and saw under the sun that the race is not to the swift, nor the battle to the strong, nor bread to the wise, nor riches to men of understanding, but nor favor to men of skill, but time and chance happens to them all. Mr. Vice Chancellor, sir, the Deputy Vice Chancellors, Registrars, Librarians, Bursars, Provosts, Deans of Faculties, Professors, Directors, Head of Departments, colleagues, students, invited guests, distinguished ladies and gentlemen. It is indeed by time and chance at the mercy of God that I stand before you today as the first female professor of morbid anatomy at the Obafemi Awolowo University and the first female consultant pathologist at the teaching hospital. So then, it is not of him that wills, not of him that runs, but of God that shows mercy. The first inaugural lecture from the department was delivered by Emeritus Professor Odesomi, a foremost professor of forensic pathology in Nigeria, long before I started my residency program at the teaching hospital in February 1996. The second lecture was by Professor Ojo, entitled To Judge the Living and the Dead. The third lecture was delivered by Professor Olasode, titled Can This Bone Live? A Journey into the Anatomy of Disease. Thereafter, Professor Kayode Adelusola gave a lecture on praising the dead that's already dead. Mr. Vice Chancellor, sir, today's lecture focuses on the changing role of anatomic pathologists in clinical decision making, providing early diagnosis and accurate diagnosis to contribute to optimal patient care and positive healthcare outcomes. Morbid anatomy or anatomic pathology. What is in a name? Your name identifies you. Names are convention that distinguishes things or people. It describes your individuality, your circumstances and responsibility. And in this case, it describes what exactly we do. The name of a discipline or department must be based on scientific standard, and it should encompass all that they do or are expected to do. The name morbid anatomy elicits some degree of fear in some people, including medical doctors and intellectuals. When people ask you, what is the name of your department? And you answer morbid anatomy, they take a second look at you and say, you are a woman, what are you doing there? Why morbid? You wonder what is going on in their mind. Over the years, the popularity of the use of the term morbid anatomy in the discipline of pathology is changing. There's a paradigm shift in the nomenclature of the discipline. The more appropriate nomenclature of anatomic pathology or anatomical pathology is presently being adopted by many departments nationally and globally, depending on whether you prefer or the American style. However, we still maintain the name anatomy and forensic medicine at the Obafemi Awolowo University, the visible pathologist. Mr. Vice Chancellor, sir, I graduated as a medical doctor from the prestigious College of Medicine, University of Ibadan in 1989. I have always been fascinated about how pathologists make their presentations and anchor the chart review sessions during our medicine clerkship rotation as an undergraduate student. The chart review is a clinical audit meeting in which the case file of a selected patient is critically reviewed and analyzed, and every decision taken by the attending physician, from the house officer to the professor, are critiqued scientifically. Thereafter, the pathology comes to present the pathological or the autopsy findings of the patient, and that is the final diagnosis. End of discussion. The purpose of the meeting is learning and not name calling or witch hunting. The meeting is usually conducted in an atmosphere of mutual respect. The questions that were seeking answers in such endeavors were, what happened? How did this patient die? What could have been done differently? And what are the limits of patients? Even as medical students, we have something to learn from such sessions. With improvements in diagnostic techniques and advancements in endoscopic and radiological diagnosis, pathologists can accurately give correct diagnosis and advise the clinician for better patient outcome. The visible pathologist does not just give a diagnosis, but is involved with patient-centered management plan for a positive patient outcome. That is multidisciplinary approach to patient management. Mr. Vice Chancellor, sir, I was not the first male doctor to start residency training in the department at the OATAC, but I was the first to complete the program and in record time also. Many of my senior colleagues in other departments were skeptical about me, a female doing residency in morbid anatomy. I hear comments like, let's wait and see. She will soon run away. Others encouraged me to change my department. I not only complete the program on time, I became a consultant and a professor in the same department. Rising through the cadre in a male-dominated department has not been an easy task. When you live among lions, you become like one, but a gentle one. What do anatomic pathologists do? I have to answer these questions many times, not just to medical persons, but even to colleagues that think we only deal with the dead. Often I get asked the question, what's your specialty? And I answered, I'm a pathologist, a morbid anatomist. And you get a reply, oh, you are the doctor we don't see. You have jettisoned your stethoscope. Your patients don't complain. Unknown to them, their samples and specimens end up under my microscope for accurate diagnosis. The pathologists combine the signs and symptoms of patients together with morphological features, including ancillary tests, to arrive at a diagnosis. In reality, the stethoscope and the microscope work together for the good of the patient. Continuous advancement in diagnosis tools has also enhanced pathological diagnosis. In essence, an anatomic pathologist makes tissue diagnosis. The visible pathologist. The increasing work of an anatomic pathologist has led to further sub-specialization in organ-specific pathology, such as breast pathology, gynecological pathology, gastrointestinal pathology, neuropathology, forensic pathology, to mention a few. Autopsy and forensic pathology. Most people think of anatomic pathology in relation to autopsy alone. Traditionally, autopsy is in the domain of an anatomic pathologist. However, that is not all that we do. Autopsy constitutes about 30 to 40% of the work of an anatomic pathologist. Most of the available knowledge on new and emerging disease are obtained from examination of those who have paid the supreme price. May their soul continue to rest in peace. Mr. Vice Chancellor, sir, in 2010, we conducted a study on pattern of death at the OE20 over a 30-year period. Infection was the most common cause of death, followed closely by trauma death and neonatal death. The study also showed a gradual increase in death from cancer over the decades. A further study on the pattern of death in females, published in International Journal of Women's Health, showed that the deaths due to trauma constituted 57.2% of deaths in women. This is more than triple the proportion of obstetric deaths that constitute 15.8% in the cohort. Injuries sustained from automobile accidents were responsible for most of these trauma deaths. Sadly, these findings have not changed over the years. The WHO in 2023 reported that approximately 1.19 million people die every year as a result of road traffic crashes. Effort directed at enhancing road users' adoption of preventive behaviors should be encouraged. The efforts of the Road Safety Corps in the last year's campaign, which was Speak Up Against Dangerous Driving, which kills more passengers than drivers, is highly commendable. We must all join hands together to stop this untimely death on our roads. Emi Olaro, Onimoto Orasare. Extensive misuse of antimicrobial drugs with resultant antimicrobial resistance still contributes in no little way to mortality due to infections. Antimicrobial resistance threatens to become one of the biggest health challenges facing humanity if there is no effective interventions. Mr. Vice Chancellor, sir, our study on maternal mortality also shows a 38% disparity between clinical and autopsy diagnosis. This further underscores the importance of autopsy in obstetric death and the need to strengthen our maternity care. No woman should be allowed to die of pregnancy-related conditions. Surgical pathology and cytopathology. Mr. Vice Chancellor, sir, surgical pathology involves the gross and microscopic examination of surgically removed diseased body tissues. The aim of such examination is to establish diagnosis, set the disease, advise on treatment strategies, and monitor response to therapy. Tissues obtained from any part of the body are subjected to laboratory processes to make them suitable for microscopic examination. The descriptive nature of the gross pathology makes it very interesting and easy to comprehend, even to medical students. For example, you have the bread and butter pericarditis, nutmeg appearance of the liver, anchovy sauce appearance in amoebiasis, cheesy appearance of the lymph node in tuberculosis, fish flesh appearance in lymphoma, and chicken fat appearance of postmortem clots. Microscopically, we have the starry scar appearance in Burkitt lymphoma, ORL appearance in Hodgkin lymphoma, salt and pepper nuclei of neuroendocrine tumors, herringbone pattern in soft tissue tumors, and the fried egg appearance of oligodendroma, to mention a few. Mr. Vice Chancellor, sir, I was nurtured and mentored in anatomic pathology by my senior professors and teachers in the department. The quartet of Emeritus Professor Desomi, Professor O.S. Ojo, Professor Adelusola, and Professor B.J. Olasode. Thank you, sirs, for nurturing me. I've been consciously and unconsciously learning under their tutelage. As a female pathologist, I was naturally interested in diseases that affect women and how these trends can be curtailed. And this is the focus of my research, gynecological and breast pathology. The breast is a modified skin appendage which is functional in females during lactation but rudimentary in males. The breast is located in the anterior chest wall and spans between the second and sixth costal cartilage. It extends horizontally from the lateral body of the sternum to the mid-axillary line and lies superficially on the pectoralis major and anterior and serratus anterior muscle. At the center of the breast is the nipple surrounded by a pigmented area of the skin called the areola. The areola has numerous sebaceous glands that secrete oily substances that lubricate the nipple during pregnancy. The shape and the size of the breast vary from person to person. are also vary with the reproductive history of the woman. The archetype breast is round and full with a small point at the center, the nipple, just as the maiden breast described in the Bible by Sons of Solomon 4:5. Your two breasts are perfect, like two young deer that are twins that feed among the lilies. Even in the same individual, the size of the breast varies from one side to the other. Breastosis or saggy breast occur as the women get older. This is completely a natural cosmetic change. Aging, collagen deficiency, estrogen deficiency, gravity, body mass index, and smoking are some of the causes of saggy breast. Mr. Vice Chancellor, sir. Developmental abnormalities can occur in the breast, but it is very rare. One common one is the failure of development of the breast, called amesia. Amesia refers to congenital absence of the breast tissue, the nipple, and areola. Amesia dates back to antiquity. The rest of the scriptures in Sons of Solomon 8:8 said, we have a sister, and she has no breast. What shall we do for our sister in the day when she shall be spoken for? Nowadays, techniques are banned for breast reconstruction and enhancement in such individuals. These of the breasts are numerous, and the most common one are inflammatory lesions, fibrocystic disease, and gynecomastia. But of importance is the granulomatous mastitis because it can mimic breast cancer. This is a specific form of mastitis in which there is granuloma formation and can be induced by a plethora of conditions, including infectious and non-infectious conditions like tuberculosis, cryptococcus, actinomycosis, idiopathic global mastitis, foreign body reaction, breast implants, and even suture materials. These are very important disease entities because their clinical presentation may mimic breast cancer. We documented a case of a 54-year-old postmenopausal woman, a pig farmer, who presented with a painless right breast mass, which was increasing in size. The mass was provisionally diagnosed as right breast cancer, and she had excisional biopsy done. Pathological examination of the tissue confirmed cysticercosis. Cysticercosis is a parasitic infection caused by the larva of pork tapeworm, Tinea solium, which is transmitted by fecal-oral routes. The patient was treated, and she's been okay since then. Mr. Vice Chancellor, sir, breast diseases also occur in males. The most common lesion in males is gynecomastia. This is a benign enlargement of male breast, typically presents as a palpable subareolar mass and breast pain. Gynecomastia must be thoroughly investigated to exclude malignant lesion. In a review of breast lesions in our practice, we found that gynecomastia represents 70% of cases of breast cancer seen in males. Neoplastic breast lesions. More than 60% of breast lesions are benign. Of these, fibroadenoma represents 40 to 43%, and most of the patients are between the age of 20 to 30 to 29 years. Neoplastic change is rare in fibroadenoma. However, neoplastic change can occur, and this underscores the importance of pathological examination of every lesion removed from the breast, no matter how innocuous it looks clinically. Cancer of the breast remains the cancer-related deaths in women in Nigeria and worldwide. In Nigeria, there's an increasing incidence, high mortality rate, late presentation, and early age of occurrence compared to other populations. In Nigeria, with age standardized ratio of 39.2 to 59.3%, while the mortality rate is still very high at 19.2 to 38.9%. Mr. Vice Chancellor, sir, our initial review of breast cancer cases in ATODIA showed an age range of 22 to 82% with peak age of 40 to 49%, and invasive doses of them presenting in stage 3 and 4 disease. We went further to conduct a multi-center study involving 6 tertiary institutions, of which 835 fulfilled the inclusion criteria. This was the largest cancer data from Nigeria and sub-Saharan Africa from literature then. The immunohistochemistry for the study was conducted at the Leeds General Infirmary UK in collaboration with our international partners using the tissue microarrow technology that was not available in Nigeria then. Many thanks to Dr. Olorundaro Timi, a worthy alumnus of this great university, for his role in facilitating the project. A comprehensive panel of hormone receptors and proliferation markers, about 13 of them were used for the study, and the breast cancer were classified into 5 recognized taxonomic groups. The results were shown in table 4. The predominant molecular subtypes were non-basal triple negative type, followed by HER2 positive groups. Based on our findings from the study, We concluded that breast cancer from Nigerian women were predominantly high-grade, triple-negative profile, and tends to occur in younger age compared to Caucasians. The molecular profile were also similar to those found in Caucasian women. This research was supported by UICC ICRE grants and the Breast Cancer Research Trust of the United Kingdom. Mr. Vice Chancellor, sir, immunohistochemistry is very important in the management of patients with breast cancer, lymphoma, and soft tissue tumors. Hormone receptor analysis is critical to management of patients with breast cancer. Immunohistochemistry services was officially launched at our department in the hospital in June 2007 during Professor Alisola tenure as head of department as a result of collaborative efforts of Professor Ojo Olasode and other stakeholders with the active support of the then Chief Medical Director, Professor Sanya Adejuigbe. Previously, our patients have to travel to UCH Ibadan to access the service. Though we started small, our competency has improved over the years. Presently, our department has the largest repository of antibodies in Nigeria, and the efforts of the African Research Group on Oncology, ably led by Professor Olusegun Alatishe, is recognized and appreciated in this regard. We are also recognized by the Federal Ministry of Health as a center for immunohistochemistry services in Nigeria. Multidisciplinary approach to breast cancer management. Multidisciplinary approach to breast cancer management cannot be overemphasized without the surgeons. As a pathologist, I have to relate directly with surgeons like late Professor Arigbabu, late Professor Adesukomi, Professor Lawal, retired, Professor Agbakuru, retired, and the present team of surgeons. We pathologists in Ife have a good working relationship with our surgeons, and we are proud of them. The relationship is robust, and I have produced great research collaborations, of which is the birth of AGO. As a team, we analyzed our institutional breast cancer databases of 607 patients, and most of these patients had palpable mass and advanced disease. 40% were estrogen positive, while 38.8% were positive, were triple negative. There's an increase in HER2 positivity. The large cohort highlights the dual burden of advanced disease and inadequate access to comprehensive breast cancer care, especially radiotherapy in Nigeria. There's a dire need to increase radiotherapy access to patients with cancer. Patient outcomes can be improved by promoting early diagnosis and facilitating access to multimodal treatments. Other prognostic markers for breast cancer. P53 is a small suppressor gene that plays a key role in many cellular pathways, controlling cell proliferation, cell survival, and genomic integrity. We investigated P53 expression in our women and found positive expression in 52.9% of cases. The level of P53 expression was high in triple negative, high-grade tumors with significant association with HER2 expression. These findings reinforce the notion that P53 overexpression may be associated with aggressive behavior of breast cancer in some patients. Cytopathology. Mr. Vice Chancellor, sir. At the beginning of my residency program, I was much interested in cytopathology, even though it was not required of me at the level of my training then. Cytopathology is usually done during the senior residency stage. I was fascinated by the purple and pink colors of the cells. I got interested because of the simplicity of the process, short time at arriving diagnosis, and seeing the beautiful details of the cells from a lesion in a well-prepared cytological smear. Cytopathology is also very relevant in breast and female genital tract pathology. I was trained in the rudiments of cytopathology by Professor B.J. Olasode. Professor Olasode popularized the use of cytopathology, especially fine needle aspiration cytology, as a diagnostic tool for rapid diagnosis of palpable breast lesions in Ife. FNAC has become a valuable tool in preoperative assessment of breast masses and presently a well-established tool for preliminary investigation of suspected breast carcinoma. Differentiating benign and malignant lesions is one of the major goals of FNAC. And since majority of patients attending breast clinic present with benign lesions, FNAC has helped to drastically reduce the waiting time of patients at the breast clinic requiring tissue diagnosis. The materials needed for FNAs are very simple: needles and syringe, glass slide, and fixative. Though the frankincense handle for the syringe is not readily available here, we have been able to perfect our skills of aspiration. Good yield. FNAC is usually done as an outpatient procedure with no anesthesia, except in specific circumstances. The procedure is quick and mild needle pain. Reports can be obtained within 2 hours to 48 hours, depending on the urgency. It is cost-effective method of quick diagnosis, but the training of cytopathologists is not cheap. It's a subspecialty training in anatomic pathology. FNC affords cytopathology direct interaction with patients. It allows first-hand knowledge of clinical findings that can enhance interpretation of microscopes from the breast, enlarged lymph nodes, thyroid, soft tissue masses, salivary glands, and palpable abdominal masses. Other sites of the lesion that may be used is prostate test of FNC, a poorly prepared smear with distorted cellular morphology. We frustrate the best effort of the most competent cytopathologists. The sensitivity, diagnostic accuracy, and specificity of FNC depends on the skill and competency of the attending laboratory physician. Mr. Vice Chancellor, sir. In Ife, we can proudly declare that we have a high degree of sensitivity and specificity for FNAC. Over the years, our diagnostic accuracy has increased from 70.8% at inception to 97.3% for benign lesions and 100% for malignant breast lesions. These findings were documented in reputable journal. Advances in interventional radiology has made image-guided aspiration and biopsy very accessible, thus increasing the material available for cytological and histological diagnosis. FNAC have been found useful in evaluation of extremely ill patients with liver disease. A preliminary report of when you do FNAC of liver lesions from our center show a sensitivity of 85% by blind percutaneous aspiration. Ultrasound-guided aspiration in later years with improved skill showed a sensitivity of 95%. In fact, the competency of cytopathology and radiologists in Ife in obtaining adequate sample for accurate diagnosis has improved greatly to the extent that FNAC of the liver have been adopted as one of the established guidelines for evaluation of extremely ill patients with liver disease, where clotting profile is deranged and liver biopsy is contraindicated by the Society for Gastroenterology and Hepatology of Nigeria. The pap smear. The perpendicular screening was started in 1945 by American Society for After Perpendicular and CHOP presented their paper on the diagnostic value of vaginal smears in carcinoma of the uterus. The basis of perpendicular screening of the cervix is that precancerous lesions may exist in non-invasive stage for as long as 20 years and shed abnormal cells which can be detected by cytologic examination. The pap smear is most widely used method for screening cervical cancer. It is involved just scraping the cervix with either spatula or brush or both, and the cells are transferred to a glass slide, fixed and stained, and then reported by cytopathologists. In a study conducted by our team, we described the importance of continuous pap smear screening in women. In this study, we found increased intraepithelial lesions with increasing age. The prevalence of epithelial abnormality from the study was 21.8%, and this finding was similar to findings from other centers in Nigeria. And epithelial lesions was found in the age group 41 to 50 years, with predominance of squamous cells undetermined significance as the most frequent lesion. Analysis of our hospital-based data also reveals similar findings in women, and the high prevalence of abnormal smears further stress the need for continuous screening of women to stem the high burden of cervical cancer in our women. Mr. Vice Chancellor, sir. As the consultant in charge of the Wesley Gill Hospital unit of the department, I pioneered the introduction of fine needle aspiration cytology and pap smear services at the hospital. These services are presently integral parts of services available for quick diagnosis of palpable masses and have drastically reduced the waiting time for both patients and clinicians. Ultrasound-guided FNAC aspirations has also improved localization of deep-seated lesions and increased the tissue yield of the procedure. Women's health and women clinic. As alluded to earlier, breast and cervical cancers remain the two most common cancers in women with age range at 40 to 49 years. Carcinoma of the cervix is the most common cancer of the female genital tract all over the world. Earlier epidemiological studies have shown that the incidence of this disease is also very high in Nigerian women. Concerned by this, I initiated a study on pathological pattern of cervical malignancies in southwest Nigeria in early my career, and this study reveals squamous cell carcinoma as the common histological type with preponderance among women between 40 to 49 years, at least a decade earlier than what obtains in other parts of the world. The study showed that the more malignant large cell non-keratinizing variant was the predominant histologic variant. The risk factors of cervical cancer include sexual activity, sexually transmitted disease including HPV, early age at first pregnancy, parity, cigarette smoking, and immunosuppression. In fact, cervical cancer can be said to be a sexually transmitted disease, for it is rare in virgins, pure nuns, and Orthodox Jews, and with high incidence in people with multiple sexual partners. Apart from cervical cancer, we also found chronic non-specific cervicitis as the most common non-neoplastic cervical lesions in women across all age groups. Most of these infections were acquired during sexual activities, while others may be due to reactions to chemicals, devices inserted into the vagina. This has implications for women's health. The clinical reports of this is that the control of infection will greatly reduce at least 90% of causes of morbidity associated with the cervix. High standard of personal hygiene, fidelity, protective sexual practices, and avoidance of high-risk sexual behaviors will go a long way to reduce cervical morbidity. It is not just enough to make a diagnosis, but what can we do to prevent patients coming down with the disease? These thoughts form the basis of my collaboration with the public health physicians. Mr. Vice Chancellor, sir, ladies and gentlemen, you will agree with me that it's very devastating for the family. For a woman, a wife, mother, a major support of the family to exit at this prime age of 40 to 49 years. The emotional void to the parent, to the children, and the spouse is unquantifiable. Our team, including public health physicians, Dr. Titi Abiono, Professor Kweju Esima, and colleagues, most of whom are professors now, in conjunction with the Medical Women Association of Nigeria, Osun State, initiated the Well Woman Clinic. I was actively involved in the takeoff and running of the Well Woman Clinic at the Urban Comprehensive Health Center, Eleyele, Ile-Ife. It is pertinent to mention that some men also supported the takeoff of the clinic, and this includes Professor Shegun Fatusi, who was then the HOD of Community Health Department, Professor Onikwede of Medical Microbiology Department, and Professor Bijola Sode provided the needed support for the cytological aspect of the clinic. Incidentally, Professor Olayinka Olasode is the present president of the Medical Women Association of Osun State. I remember the first time I went to the clinic at the health center. I met a colleague who was surprised to see me as a pathologist. And the usual question came, what are you doing here? Do you see patients? I smile and answer in affirmative. Yes, I do. I'm a visible pathologist. The clinic serves as a screening center for all women in the reproductive age group for early detection of breast, cervical cancer, and other women-related diseases. The clinic provides an atmosphere for a woman-to-woman consultation, which may not be easily available at a normal clinic. Adolescent girls were also given reproductive health education. One peculiar thing about the clinic that it is run by women. Many women within and outside the university community benefited from the screening exercise. In fact, the M1 Osun has upscaled the clinic to many outreaches within the states, including a similar Well Woman Clinic at the state capital, and this has also been replicated in other states in Nigeria. I'm also involved with the conduct of free breast screening examination for women groups in the month of October. And incidentally, this month of January is Cervical Cancer Awareness Month. The pattern of cervical epithelial lesions seen at the Well Woman Clinic correlates well with those observed in population screening from other centers in Nigeria. Mr. Vice Chancellor, sir. A recent publication of a study conducted by OMONIYI-ESAN 2022 analyzing the cancer registry data from 1991 to 2010 noted a steady rise in number of cervical cancer cases from early 90s with 5 spikes during the period. However, there was a marked decline in the trends of cervical cancer between 2018 up to the end of the study. And this period coincides with the time of active and intense activity at the Well Woman Clinic. This observation highlights the positive effects of cervical cancer screening exercise in reducing prevalence of cervical cancer. The need for continuous and consistent screening of women in this regard cannot be overemphasized. Human papilloma virus, a major etiological factor implicated in the pathogenesis of cervical cancer, and genital HPV infections is the most common sexually transmitted infection. A study to determine the prevalence of HPV in women attending Well Woman Clinic was conducted. And we found a prevalence of 21.6% in our women. We tested for 15 different serotypes, but only 9 were present. However, we found a predominance of HPV serotypes of 16, 53, 18, and 52 in that order. The finding of HPV 53 as the second most common serotype has implication for HPV vaccination strategy in Nigeria. Ajenifuja et al. Also found HPV 58 as the commonest genotype in the cohort studied. HPV prevalence was high not only among young women but also in middle-aged and older women. And the prevalence of high-risk HPV increases with parity. We also conducted a study on the awareness and accessibility of HPV vaccine among OAU staff. Majority of parents believe that this vaccine protects against cervical cancer, beneficial to health, and should be incorporated into routine immunization. Thankfully, the vaccine is currently available and more accessible now. The Public Health Scotland, in collaboration with researchers from 2 Scotland universities, in a recent study published in Journal of National Cancer Institute, reported that there was no cervical cancer found in fully vaccinated women who had immunization at the age of 13 to 12 years since their program started. This further underscored the importance of HPV vaccination in preventing cervical cancer in vaccinated population. There's a need for more concerted efforts to increase acceptability of HPV vaccine among women in Nigeria. The burden of cervical cancer can be drastically reduced in our society by encouraging HPV vaccination in our teenage girls. Apart from cervical cancer and related lesions, a common cause of morbidity in our women is leiomyoma, commonly called fibroids. And this is very common among women in reproductive age groups. About 20% of women have this lesion. Mr. Vice Chancellor, sir, I co-supervised a cross-sectional study comparing the expression of estrogen and progesterone receptors in normal myometrial tissue. And we found that the growth of leiomyoma seems to depend on steroid hormones, but only during early tumorigenesis. The implication of this is that smaller fibroids will respond to hormonal manipulation better than bigger ones. Thus, women in reproductive age group are advised to do comprehensive reproductive health checkup regularly so that small fibroids can be picked and treated on time. This thesis and the candidate the Best Project Award in the West Africa College of Physicians in ONG Part 2 examination, Awowole OI, estrogen and progesterone profile in leiomyoma and normal tissue. The findings of this research were also published in the International Journal of Obstetrics and Gynecology in 2016, and the publication immensely contributed to knowledge to earn the Paper International Recognition Award as the best clinical research article from low and medium income country in 2016. It is common knowledge that ovarian cancer is the second most common cancer of the female genital tract after cervix. Our group under my leadership reviewed cases of ovarian cancer and found that serous carcinomas as the most common type. The current knowledge of ovarian serous cancer indicated that the pattern of P53 mutation separates ovarian cancer into low-grade serous tumors and high-grade tumors, with implication for management and prognosis. We found that most of the serous epithelial tumor has high P53 mutation by immunohistochemistry. We also find high expression of P53 and Ki67 in cervical cancer and breast cancer tissues. Mr. Vice Chancellor, sir, a dive into medical education as a discipline. Medical education or health professional education as a discipline can be defined as the study, research, and application of educational methods and principles in the training of physicians and other health professions, with the view of ensuring continuous standard and quality, leading to production of competent and proficient healthcare professionals. The discipline promotes scholarship and research in teaching and learning across health professions while integrating educational innovations to improve methods of instructional delivery, assessment in HPV, curriculum development, and review. It plays a leadership and supportive role in guiding faculty development, educational innovations that aligns with global best practices across all health disciplines. It can be regarded as a quality control arm of all aspects of medical training, and it has evolved to a discipline of its own and has its own subspecialty. My background as a medical teacher. Just like many medical educators and university lecturers, we started as content experts, except those with basic education degree. from appointment letter to the classroom. I've been teaching anatomic pathology for almost 15 years as a content expert before I had my training in medical education. My teaching experience usually started as a junior resident doctor in 1996 when I began moderating anatomic pathology tutorials for 4th year medical students and 5th year dental students then. You are not taught how to teach. Just go and teach the students. I'm sure many of us in this room can attest to that. My teaching method initially was teacher-centered, traditional teaching, as we were taught in medical school. Things should not continue like that. There's a paradigm shift in instructional methods of delivery, and we need to change. However, with my new knowledge about how students learn, I have to adapt my teaching to the innovative student-centered instructional method. Health professional educators start at advanced position to revolutionize the health system for a better patient outcome. I conducted a study on perception of medical students and dental students about their learning environment during pathology rotation. Students have to shuttle between the university campus and teaching hospital every day during the placement. The structural organization of this learning environment and experiences of students during the period prompted the study. The findings of this research gave an insight to how students perceive their learning environment during the rotation. 5 different learning domains were evaluated: student perception of learning, perception of teaching, academic self-perception, atmosphere of learning, and social perception. Though the overall score is above average in 4 of the 5 domains, the social perception is below average, and there's need for improvement across all domains. When students were asked about teachers providing good feedback, the response was below average. There's a need to improve our feedback system. Sometimes our students don't have access on time to how they perform in examination. Effective feedback system with formative assessment will guide learners in areas that need improvement and positively impact overall performance and competencies. Feedback should, however, be conducted in a comfortable and safe learning environment with objective to reinforce learning and not to bully or abuse students. Students should be comfortable to ask for feedback about their performance. This study provided students an avenue to share their experiences as a useful evidence to modify and improve the learning environment during the pathology placement. We further investigated the perception of learners on applicability of preclinical courses, that is anatomy, biochemistry, and physiology, and the clinical training at IFE. The study was conducted on final year medical students and dental students and newly qualified doctors at the college. Physiology had the highest applicability compared to other 2 subjects. Anatomy was perceived as the most overloaded subject, while medical biochemistry had a low score. Mr. Vice Chancellor, sir, it is to be noted that the performance of students in biochemistry has really improved after the study. A faculty member in the department has to take a year off to study medical education as a discipline. Now we have many students with distinction in medical biochemistry. I encourage many more faculty members to join us. The importance of integration in medical education was brought to fore again by respondents. As part of my MPhil program, I conducted a research on perspective of foundational teachers about integration of courses in basic medical sciences. The study revealed that the teacher supports integration of courses to enhance teaching while encouraging student participation and understanding. However, institutional and infrastructural support is required for the success of such endeavors. Faculty development. The university and the college must be intentional in training its workforce, and it's assumed that every new lecturer knows how to teach and what to teach. Mr. Vice Chancellor, sir, the Promoting Excellence in Teaching PET program for all newly recruited academic staff that was introduced earlier by the university is a very novel idea that should not be allowed to go into extinction. It can be expanded to a robust program for both new and existing staff of the university. As a member and chairperson of the College Health Professional Education Committee, we have facilitated capacity building activities for the staff of the college. These activities were made possible by the kind and generous support of our dear Provost, Professor Babatope Kolawole. The Health Professional Education Committee was reactivated in 2021 and has a 10-member committee as listed, and the committee has developed a proposal for the establishment of the Center for Health Professional Education in the college. We have also developed implementation plan for systematic capacity building for health for college academic staff. Though the program has not been implemented as planned, due to logistics, we have been able to organize virtual workshop on establishing HPV units with resource persons from University of Lagos, Ibadan, and Ilorin, upscaling your communication skills and assessments in HPV. The feedback from all this workshop is a pointer to the fact that there's need to institutionalize HPV as a discipline. As a team, we are presently working on the project titled Development and Online Training Program in Health Professional Education for College Staff in Ife, in collaboration with Academic Without Borders, USA, with Professor Ezeyi as project lead. The major content of this project is completed and the website development is presently ongoing. Mr. Vice Chancellor, sir. Apart from undergraduate medical education, I'm also actively involved in training postgraduate doctors. I've trained and mentored many postgraduate doctors in anatomic pathology. Some of them are professors today and head of department within and outside the country. I've supervised and completed 14 dissertations for candidates for both West Africa and National Postgraduate Medical College in pathology, hematology, obstetrics and gynecology, and dental surgery. 2 of the diseases were awards winning. The award Wale as mentioned earlier, and Dr. Father Hunsi on prevalence of high-risk HPV among women in the Well Woman Clinic for FMC part dissertation in 2013. Another of our articles also won the Frederick Sanger Award for the best publication by Photon Journal of Pediatrics. I've also supervised and examined many master's and PhD theses. And were published both locally and internationally. I have, to my credit, over 65 academic publications and contributions to books. I've contributed to writing a medical textbook titled Companion to Tropical Medicine, edited by Olusayo Alebioshu. I'm also involved in writing the new edition of the Essential Pathology for Medical Students, edited by Professor O.S. Ojo. I'm a recipient of several travel and research grants, which include British Division of International Academy of Pathology travel grants to attend the Congress in Cape Town 2012, the tertiary education grants to attend the British Division Academy in London, UK, and then also to attend the Gynecological Pathology London, UK. I've also received the OAU URC reserve grants for the project Health Promotion Intervention at Community Level to increase breast cancer awareness and management. I'm currently a co-investigator in a recently completed TED-Fund-sponsored research project titled Molecular and Immunohistochemical Characterization of Some Cancers in Southwestern Nigeria. I'm currently involved in Center for Medical Informatics and Professional Development projects on cervical cancer screening and human papillomavirus automated visual evaluation project on cervical cancer lesions. Mr. Vice Chancellor, sir. As I conclude, as a visible pathologist, I'm involved with multidisciplinary approach to patient care, clinical decision-making process with emphasis on detection and diagnosis, early detection and diagnosis of diseases, while implementing research findings to further improve patient outcome. A visible pathologist is not just a doctor's doctor, as pathologists are called, but also patient doctor. I also engage in improving the learning experience of students in anatomic pathology to stimulate their interest in the discipline. Mr. Vice Chancellor, sir, as I conclude, I have great privilege to be academically tutored, nurtured, and mentored and worked with Professor Odesomi, not just in pathology, but also in life experiences. Professor Ojo took me through the rigor of writing full autopsy reports and supervised my part 2 dissertation. Professor Adelu Soda also supervised my academic, is also my co-supervisor and academic mentor. Professor Olasode, as I mentioned earlier, taught me the arts and science of cytopathology. Dr. Professor Komolafe, our forensic expert, and Dr. Olaofe, my HOD of professors. Thank you all. My colleagues in hospital, you deserve a special mention. Dr. Shore Mekun, Omoyola, Betiku, Adefidikpe. These are associate lecturers in the department who have been teaching and conducting examination for medical students pro bono for the past 3 years. The lecturer is worthy of his rewards. The technical staff, heavily led by Dr. Adego Kade Aremu, and his team are well appreciated. There's no surgical pathology without the surgical team. Special appreciation to surgical team as listed. The AGO team, the whole surgical team has been very amazing, and they are partners in progress. The multidisciplinary approach to patient care has been very rewarding. The OMONIYI team are also well appreciated, and many so others that I could not mention for short of time. Special thanks to Dr. Titi Abiono, my dear friend, Professor Olapejo Esimai. Happy birthday today, and the community health team for providing the springboard for the Well Woman Clinic. The M1 support over the years as the main stakeholder is well acknowledged. Acknowledge the contribution of my late mom and dad. My mom, though she did not have formal education, but she was a very wise woman. With her entrepreneurial skills, she knew how to use little money for big projects. My dad was also saying, I'll be a medical doctor, even before I entered medical school. May their soul rest in peace. My siblings appreciate your support for me all through the journey of life. Thank you all for believing in me. Whatever you are seeing today is a manifestation of the works of redemption in my life. Special thanks to my spiritual parents, Daddy and Mommy, Reverend and Reverend Mr. Olushola, and Oyenike Areogun. Though I may have many instructors, but I have only one Father, for in Christ Jesus you have begotten me. There are many things that money cannot buy. Those are the things you put in my heart as a father. I cannot ask for a better father. The Dream Center pastors, deaconry members, thank you all for continuous support and pastoral care over the years. All Holy Ghost. To my hubby, continue to rest in the bosom of the Lord. To my children, thank you for loving mommy. And finally, to the only wise God, our Savior, be glory and majesty and dominion and power, both now and forever. Amen. Great is thy faithfulness, O Lord. Thank you for listening.
God, my Father, there is no shadow of turning with thee. Thou changest not, thy compassions, they fail not. As thou hast been, thou forever wilt be. Summer and winter, springtime and harvest.
Thank you very much. Presentation of certificate. Obafemi University, Ife, certificate of presentation of inaugural lecture. This satisfies that G.O. OMONIYI-ESAN, a professor of morbid anatomy, Department of Morbid Anatomy and Forensic Medicine, Faculty of Basic Medical Sciences, College of Health Sciences of Obafemi University, Ife, Nigeria, delivered the 389th inaugural lecture titled The Visible Pathologist, a paradigm shift in the practice of an anatomic pathology.